here? All right. Well, hello everyone, and welcome to our speaker series webinar for spring 2025. My name is Tatiana Shippey. I am a professor at the University of Minnesota School of Public Health, and I serve as the Associate Director of Research for the Center for Healthy Aging and Innovation at the University of Minnesota, or CHI. I'm a white female with brown hair and green eyes in my 40s. At CHI, we envision a world where every individual can achieve their life goals while aging. We work toward this vision through education, research, policy, and equity-driven community engagement. Each year, we select topics that are of high interest to our members and community partners. This year, we are focusing on disability and aging, a critical and timely discussion. Today's webinar will explore the intersection of aging and disability, highlighting the importance of bridging research, practice, and policy across both fields. We are pleased to present this event in partnership with the University of Minnesota's Institute on Community Integration. Before we begin, I want to share a few accessibility notes to ensure an inclusive experience for everyone. Captions are available. You can turn them on or off at any time using the Zoom toolbar. This session is being recorded, and both the recording and slides will be shared with attendees afterward. Our team is monitoring the chat for any accessibility or technical issues, so feel free to reach out if you need assistance. And the general layout of today's webinar is as follows. You'll hear a 25-minute presentation from our main speaker, Dr. Putnam, who I will introduce shortly. Her presentation will be followed by a panel discussion with a group of local experts here in Minnesota on this topic. We will have dedicated time at the end to answer any questions you may have, so please add them to the Q&A box throughout the presentation. Now, we'd like to get to know the participants of this webinar a little bit. So we're going to launch a quick poll to learn more about what brought you to today's webinar. And Alicia is going to launch a poll shortly. Great. The questions are, I work in aging or disability policy research. Second one is, I provide direct services in aging or disability. Then it's, I have personal lived experience with aging and disability, or I am here to learn more about this topic. So we'll just wait a minute as you can identify which best corresponds to your experience. Okay. Alicia will show us the results. All right, this is really helpful to see. So about 39%, our largest category, are those who provide direct services in aging or disability. Welcome. That's followed by 36% of you who said that you work in aging or disability research. Welcome. 18% are here to learn more about the topic. We're glad to have you. And another 7% have personal lived experience with aging and disability. And I'm so glad you could join us, and hopefully we'll hear from you in the Q&A session. So with that now, thank you all for participating again. I would love to introduce our main speaker today, Dr. Michelle Putnam. Dr. Michelle Putnam is the new director of the Gerontology Institute at the University of Massachusetts, Boston, and is a leading expert in aging and disability research with extensive experience in academic leadership. Formerly at Simmons University School of Social Work, she is a member of the National Academy of Social Insurance, serves on a national advisory board on improving healthcare services for older adults and people with disabilities, and is the editor-in-chief of Innovation in Aging. Welcome, Michelle.
Thank you. Thank you so much for having me. Welcome, everyone. I'm really glad you're here, whether you're here in person or maybe you'll be listening to this recording later. I am a white female. I have short brown hair. I'm wearing glasses today, and I have on a dark turtleneck shirt. Because you said your age, Tatiana, I'm gonna say I am in my 50s. So that is your visual for you. I'm delighted to be here. I'm going to share my screen in just 1 second. I wanted to preface this by saying I will do my best to speak slowly and to get through all of my slides. I am a professor, so that is a little caveat that sometimes we tend to go long. So I have my clock going. So if I look down, that's why. So I'm going to go ahead and share my screen with you. Today, the topic for today is bridging aging and disability. And I put on here continuing forward. My slides are a little bit different than they might have been a short time ago. First, I should make sure. Can everyone see my slides okay? Yes. Okay, thank you. So for those of you in the audience may have noticed, as I did last Thursday, the federal government put out notification that it would be changing the structure of the Department of Health and Human Services. And one of the things that they're intending to do is change the administration for community living and change the organization of that agency, which has responsibility for the Administration on Aging programs, Older Americans Act, and also many programs that are for people with disabilities of all ages. So I changed my presentation a little bit for today with some thoughts that we may not exactly know what's coming down the pike, but we still want to think about bridging. And I wanted to start by saying that in 2005, I gave one of my first talks about bridging aging and disability at the Odyssey Conference in Minnesota. I was fortunate enough to have Dr. Rosalie Kane as a mentor of mine as I started out this work, and fortunate to be working on a study that she provided some guidance on. And I came to this conference and presented on the topic and presented some of the work that I've been doing. So as I prepared for this talk, I looked back to that to think about where we were in 2005, where I was when I started this work. And we really started thinking about silos at that time and the silos we were in. We had programs and services for older adults, for people with disabilities, physical disability, people with intellectual and developmental disabilities, and people with psychological disabilities. So we're in this siloed space. And that's some of what interested me into this topic, as a lot of my training is in gerontology, but also in disability. And I moved into this conference and we talked about the new landscape that was being shaped at the time, because just as I was starting this work, the framework, the policies, the structures around it were changing too. So we had the Americans with Disabilities Act in 1990. Oh, I had my date wrong there, in 1999, sorry. And the sorry, the ADA is in 1990. The Olmstead decision is after that. It's not 1991. I have a typo there, my apologies. The Olmstead and the Supreme Court decision that made push forward civil rights for people with disabilities, regardless of their age, related to care. So that decision really changed the way that we think about long-term care, in the way that we even talk about it, changing it to talk about long-term services and supports, because that decision really told us that people with disabilities have the right to receive care in the community and be part of our communities, regardless of whatever supports and services they need. We needed to stop our focus on institutionalization. And from that Olmstead decision, and then the New Freedom Initiative that came after that, with it, which was an executive order, we saw things start to change. We saw a rebalancing initiative in Medicaid. We saw a money follows the person program where people were able to take the money that was being spent on them in institutional care and move that and use that in the community. We saw consumer-directed care and research on that grow, where people were able to hire and fire their own workers and think about what they wanted to buy and use for services and supports. And we saw the development of aging and disability resource centers, so trying to knit together the fragmented set of services and supports that were in the community for people, so that they could better get their needs met. Well, so what we really saw was this push to reduce institutionalization, largely driven by the disability rights movement, in the desire to ensure that people actually could act on and achieve their goals by having these civil rights in action in the community. So coming back to the silos, one of the things that happen is thinking about, why do we have these silos? Why do we have these services and supports in different systems and policies? And these silos really reflected our historical thinking about population needs, about thinking about workers, working age people versus retirees, older adults. They related to our beliefs and ideas about disability. So whether we were thinking about disability as a medical thing, something that happened to people, and that's sort of traditionally where gerontology was at, or if we saw this as something situational about the environment and the person in the environment, and whether that supported all types of people and different types of people. And these silos really reflected structural and policy legacies that we have relating to these beliefs and ideas. They became pretty hardwired. And we also had a lack of cross aging and disability work, research, policy practice. Things were pretty separated, except for in some unique cases where maybe a town, a city, a community, a state, an individual took it on themselves to make some pathways there. So there was this real need for bridging work, and that Olmsted decision really drove it forward. And that led to thinking about, what is bridging? So what is this about? And bridging isn't unique to aging and disability fields. Bridging is talked about in lots of different fields. But fundamentally, the work that we saw at the time and the work we see now has come forward to think about bridging as a strategic, practical thinking about what we're doing, about creating opportunities to work across divisions by intentionally building pathways to do that, and by bringing together and applying the best knowledge we have, the best practice we have, the best policies and ideas we have from disciplines and fields in research, policy, and practice. So at that 2005 Odyssey meeting, I talked about the intersections of aging and disability. I had a much more detailed slide, but generally it sort of comes down to this, thinking about what people want, regardless of how old you are. What do they want? So people want to live where they choose. They want to make their own decisions. They want to participate and be engaged, regardless of their age, regardless of who they are, where they live, and they want to be healthy and well. And that's sort of these core pieces of the intersections that a lot of different work has come across related to, but that's sort of from my perspective, the fundamental piece. So at that Odyssey conference in 2005, I had been working on this study, and which produced this book in 2007, where I talked to stakeholders asking, what are the facilitators and barriers to these cross-network collaborations and coalitions? And they sort of came in these four buckets. One was organizational characteristics. The other was collaborative, what helped maintain a collaboration. Another one was past experience. And another one was marketplace conditions. What was out there that would support this type of collaboration? And there were barriers and facilitators, and they look kind of parallel. So for organizations, whether you had the administrative structure, the staff, the time, the money to do this type of work, whether you thought your consumers or stakeholders were similar or not, in terms of relationship maintenance, whether there was a strong structure to the collaboration or not, whether there was very much investment in it. Past experience was things like whether or not you tried it before and it didn't go well, or it did go well and you had good partners to be working with. And then marketplace conditions were really about competition, different agendas, different philosophies, maybe about how you approach your work or how programs or services should be delivered. And then risk, how much risk would it take to engage in this work? So for me, looking back 20 years, a lot of this still remains true. and thinking about what helps and what gets in the way of working across agent and disability network groups. But a lot of it has changed too. And I want to just pause for a second to mention that this bridging work has been going on for a long time. It's sort of ebbed and flowed in terms of how we think about it or how much it's come to the forefront or not. But I like to cite this Wingspread conference in 1987 as the first meeting I found where the participants really focused on bringing aging and disability together. This was a conference that was focused on aging and lifelong disabilities, people with intellectual and developmental disabilities, partnering for the 21st century, which is where we are. After that, there are many different conferences and meetings, usually fairly small, but there were these declarations that came out of some of these too. And I'm highlighting these three here. There was one from Graz in Austria on the Declaration of Disability and Aging in 2006. There was one in 2009 that came out of Barcelona, Spain, related to long-term care and support. And there was one in Toronto on bridging knowledge, policy, and practice in aging and disability that I was a part of. And I highlight these because sometimes we think that what we're doing in the United States is particular to us or that these challenges are particular to us. But this is really an international thing, bridging aging and disability. So many countries have set up their systems and structures based on age, based on life stage, based on the thinking about what people who experience disability, what that looks like in later life versus what that looks like in younger life. So this need to bridge is pretty universal out there. And from that, there's been a small body of work that's emerged. It's not huge, but it's meaningful. There have been meetings, reports, initiatives, scholars, and advocates who focused on this. But I like to think one of the most important things that facilitated some of the bridging that we've seen in the United States was the establishment of the Administration for Community Living in 2012. So the Administration on Aging was many of the disability programs, as I mentioned a few minutes ago, were brought into the fold of ACL. And there were a lot of challenges to that. Different constituencies thought different things at different times and probably still have along the way. But the primary idea was about knitting a stronger web of help for people with disabilities of all ages, people who are aging of all abilities. And that umbrella has had a lot of meaningful impact over time. So when I look 20 years later from where I started to talk about this topic, I see that there are significant achievements. A lot of them are forwarded by the Olmsted decision and its implementation. Um, that's changed the way that we think about long-term care 20 years later, I would argue. It's helped reorganize and restructure our marketplace from sort of defaulting to institutional care and nursing home care to thinking about home and community-based care in a bigger way. It's changed the payment structure. It's incentivized differently being in the community. There's still a large amount of challenge in terms of waiting lists, in terms of funding, in terms of availability, all sorts of things. But in terms of shifting the direction of the boat, that decision helped us do that. It helped us advance consumer preferences and think more about what the person in this equation and what they would like. And it has helped foster different innovations out there. And I wanted to highlight some ACL cross-network initiatives that I think have helped us move stepwise farther. So we saw these aging and disability resource centers develop that tried to knit together the community-based services and supports a bit better. We've seen things like the Aging and Disability Business Institute that has tried to work with aging and disability organizations to better work with the healthcare sector. We've seen initiatives for aging with intellectual disability and communities of practice. And then we've seen on the research side, the National Institute of Disability, Independent Living, and Rehabilitation Research continue to fund grants on aging with disability and that population that's living long-term with disability. So we have seen movement, and I would argue a reasonable amount of movement in a fairly short amount of time. We still have a lot of challenges. when I think about bridging. And a lot of that is about investment, I would argue. So, and our thinking. So, some of the challenges are old, from my perspective, older adults and people with disabilities remain distinct focal groups within programs and policies, and as well as research. So, we haven't done as well about thinking of pathways across the life course. Those pathways are pretty thinly built. We still tend to group people into older adults and younger people with disabilities. um, we still have a situation where individuals and families remain, I would argue, very unsupported in the work that they do to help the people in their family and their communities, and they're heavily engaged in providing care. There's a lot of out-of-pocket costs. There's certainly nothing wrong with helping your family. Everybody wants to do that, but the burden is really high for a lot of people, and the costs are really high. And I think that that's not the best situation, or the situation we want to be in. Um, Long-term care and supports and services remain costly. They're hard to find. They're varying quality. We still have an issue with who pays. We don't have long-term care or independent living care insurance. And a lot of the issues that people experience, a lot of the care, a lot of the needs, a lot of the struggles that people are having remain fairly private. They haven't really moved out in the public into that community sphere. So a lot of times people still feel like they're starting from zero. They're the only one, or they don't know where to start. So sort of our focus on thinking about involving people in our communities, regardless of their age, regardless of the type of disability they experience, our focus on removing that disability, on integrating people, hasn't advanced that far. We've gotten farther, but we probably, in my opinion, haven't moved far enough. But we have seen some of these structural changes, which I think are moving us in the right direction. So, sort of coming up to this 20 years, here we are with a very recent announcement that we're likely to see radical change in the federal infrastructure, and potentially a different focus and a different commitment. Um, so for me, that leaves us thinking about what's next, what's happening now. There's been a huge amount of investment in the structure and system that we've had in a lot of incremental change. And I'm not quite sure what's next, of course. How could we be exactly at this moment? But what I did do, and what I started to think in the past few days, is sort of coming back to things we know, and what and how we can think about bridging, how we can think about moving this forward. And so the professor part of me started to pull out some charts, because I think one of the things that we can think about is this: what do we know about the population? So I apologize for this kind of super dense chart. I'm not expecting you to read it. I just want you to look at the image, and I'll describe the images. So I have this measurement of this snowman, which I feel is apt for Minnesota and Massachusetts, where I am. So if we look at this snowman that has three balls of snow that make him up with a hat on top, what this chart is showing is that our population is growing and it's squaring. So this first image I have is from 1980, and our age pyramid is wider at the bottom. So our snowman is wider at the bottom and thinner at the top up to his hat. And we have about 227 million people in our population. We moved to 1990. Our snowman is a little thicker in the middle than he is in the bottom, and still kind of thinner at the top. And we have about 250 million people. And then we see in 2000, we're at 282 million people. And our snowman is a little thinner at the top than he is in the middle of the bottom, but he's filling out. And then by the time we get to 2010, we have 309 million people. So we keep growing our population, which happens. And our snowman is a little more, getting a little more square with a little more triangle at the top. And then we get to 2020, and our snowman's pretty square with a smaller top hat, and we have 331 million people. So the reason I'm showing you this is that regardless of what our structure systems, how we're thinking about what's happening and the way that we're setting up our programs and services, our population is increasing numerically significantly over the past few decades, and it's squaring. So it really is that we have a lot of people at a lot of different ages. So we've always think about the baby boomers and how they're moving through the system. But I think sometimes when we see a visual like this, we can just see that we're looking at a lot more people at all ages at the same time in our population. And I think sometimes this visual can help us think a little bit differently about disability in that population too. And just for fun, I wanted to show you the Massachusetts and the Minnesota descriptions and highlight that states are different. So when we think about solutions in different places, different states have different population distributions. The image on my left is of Massachusetts, where the median age is almost 40 and 19% of the population is under age 18 and 17.5% is over age 65. And that snowman looks like it has a belt cinching in its waist a little bit, which I don't know for sure, but that just could be like the college students and then their professors are above and below that belt. I'm not sure. We have so many in our state. In Minnesota, the snowman looks a little square, but gets thinner at the top at that. So the median age in Minnesota is a little bit younger than Massachusetts at 38, and about 16% of the population is over age 65. And then I also just wanted to show you these two other states. You can look at Maine and Utah. Maine is that snowman is very top heavy. So Maine is pretty old. It's our oldest state. The median age is 45 and 22% of the population is over age 65. So it's a skinny at the bottom snowman and wider at top. And in Utah, it's the opposite. The Utah, the median age is 31, only almost 12% of the population is over age 65. So that snowman is thicker at the bottom and skinnier at the top. And again, I'm showing you these visuals just because this is what we know. We know the population is aging, and we know that it's growing. So when we think about bridging and we think about programs and supports and needs, we can think about there's a lot of people, and there's a lot of people across a lot of different ages. And then this slide, I've given you sort of a classic disability status by age group bar chart. This is, I think sometimes when we see these images, our mental maps sort of lead us to different ways of thinking. And I feel like this type of bar graph in particular has contributed to us thinking about younger and older people who experience disability as really different groups, because what we see is that the number of people or the percentage of people experiencing disability over time as they get older is much greater than it is when people are younger. So it really looks like disability isn't something that's very common at these younger ages. But when we think about the number of people with disability, it's quite common. And so I think sometimes these bar graphs kind of distort our way of thinking and maybe contribute to the way that we segment different populations. So disability is a really common experience in later life, but it's also common in younger life. It's just that the distribution of it might be slightly different. And we know that disability itself tends to be universal. What's causing disability, what's creating disability, inaccessible environments, people's attitudes and beliefs, like how we shape our world around us, that doesn't seem to be age specific in a lot of ways. Those are more universal and shared. And so I made this little funky kind of graph myself with our age pyramid. I think one of the ways that we can think about bridging forward is to think about the disability population as part of the aging population. Instead of thinking about older adults and people with disabilities, just thinking about people and just thinking about disability as part of that experience of growing older. People will have their own unique way of experiencing it, or it will happen different for different people based on maybe the chronic conditions they experience or the barriers they experience. But that's all folded in our general population. Aging is a common experience, and that's true for people with disabilities too. They're growing older. And disability is a common experience. And then in this sort of squared off snowman that I'm showing you here in this population pyramid, I have all these squiggly lines of different colors when these are not scientific at all. They're just representing different types of patterns we might see in disability. Somebody might have disability or experience disability their entire lives. Somebody, it might be just at the end of their life. Somebody, it might be midlife. It could be that it comes and goes based on the situations people are in. It could come and go based on the type of chronic condition somebody has. Disability is not usually static for anyone. The amount or severity of disability somebody experiences has a lot to do with the environment around them as much as it might have to do with any condition that they have. So I think it's much to our benefit if we start to think about that we're just us. We're just a population of people who are growing older. Some people have disability, some people don't. Some people have impairment, some people don't. That's just a variation of our humanness. And if we can think about that, we can start thinking about bridging a little bit differently and maybe less entangled or less tied up in some of the ways that we're thinking about it programmatically. So if we think about what is a bridge, it's a crossing, it's a meeting point, it's a throughway, there's infrastructure and architecture, but really bridging is an idea. It's an approach. A bridge absorbs energy and it's an energy absorbing structure that bears and distributes forces and stressors while creating a pathway across. And I think some of the critical lessons that we have had in our bridging for the work for the last 20 years is really that bridging is active and it's purposeful, that the goal is to create smooth pathways, fill in gaps, and create through lines for people over the life course so they can live well, be happy, do the things they want to do. And also, are learning and thinking more um, purposefully about when people need supports, helping people find um, their paths across the life course, navigating and using these pathways. People will need different things at different times, and that's okay. But we want to be able to help and support people when they do need it. And often what we need to have in our resource kit to help people is the same or similar, regardless of their life stage. And I also think that engaging and bridging helps us demonstrate that we value everyone, regardless of your age and regardless of your who you are, what disability status you might have. We value your contribution to our communities and that we think people have the right to live and age with dignity and good health and be engaged in our communities. So I think those are some of the big takeaways that I'm thinking about right now as we think about the changes that we might see going forward. And my last thought I'll leave you with is I think we have to keep bridging, regardless of the terrain we're in. That bridging is really an idea, an approach, something that we can do regardless of what the circumstances or what might be happening around us. And with that, I'll stop. Thanks.
Thank you so much, Michelle, for that really insightful presentation. Definitely lots to think about. Maybe let's just take one question from Q&A, and then we will transition to our panelists. And the question is as follows. ACL was created through congressional policy, right? What was the act? Is there any hope in a legal argument that the executive branch cannot dissolve it without congressional action? I don't know, whatever you're comfortable sharing your thoughts on it, Michelle.
Um, I think we don't know what we don't know. And I think there are a lot of rules and regulations and processes and procedures. It took a long time to bring all those disability programs in. It took a long time to create ACL with when you follow the rules, regulations, and procedures. In theory, would it take time to create all these new and different structures and make that happen? Yes. Is that what we're going to see? I don't know. I think there's real concern about loss of workers and lots of funding as that all rolls through. And I think we just don't know what that means.
Thank you, Michelle. Well, with that, let's transition to a panel discussion. But before it, I have one more poll question for you. And the poll question is, if you have experience with aging or disability, personally or professionally, what do you think is one important issue or challenge in aging and disability that needs more attention today? We'll just give it a couple of minutes to see your answers. And while we wait, I will answer one of the questions in chat that yes, slides will be available after the presentation. All right, let's see at the answers for the poll. I think Alicia is putting it together for us. I do not see any answers. Do you see it on your end, Alicia? Oh, somebody says that they didn't have the ability to answer.
What we we had to stop the poll to be able to read the answers that came through first. So some of the answers that came through as important issues or challenges in aging and disability were a limited direct service workforce, community living for all residences, funding with an exclamation point. All changes happening at the federal level are concerning. People note isolation, housing, rural resources, dental access, workforce, lack of resources, lack of caregivers, enforcement of the ADA, meeting people where they're at, home care, preserving ACL, mental health needs, caregiver shortages, paying for long-term care, mental health and estate planning were a few of the first ones that were answered. Thank you for those of you that were able to get your answers in quickly.
Yes, thank you all so much. And I know some of you said you didn't have enough time to answer. And really the purpose here is to get the conversation started for our panelists too. And we will share the responses we received if it's helpful for you after the presentation. So with that, I would like to introduce our panelists today. Each of them plays a critical role in our community, bringing valuable expertise and unique perspectives on the intersection of aging and disability. In curating this panel, we wanted to ensure a diverse range of voices, which include representatives from government, service providers, advocacy, and the community. So first, we'd like to welcome David Dively, who is the Executive Director of the Minnesota Council on Disability. David joined the Minnesota Council on Disability as the Executive Director in 2020 with over 10 years of leadership experience. His parents are both deaf, and his first language was American Sign Language. David is autistic and is a parent of 3 kids, all with disabilities. Disability advocacy is both personal and professional for him. His academic and leadership foci include organizational growth, systems change, and advocacy. Next, we're pleased to introduce Tori Mehar, who is the Associate Vice President of Older Adult Services at Lutheran Social Services. Tori is the Associate Vice President of Older Adult Services for Lutheran Social Services of Minnesota. In this role, Tori oversees a range of services, including caregiver and companion services, meals, trust services, guardianship, and supported decision-making. Tori is a licensed social worker and holds an MBA with a focus in healthcare management. And finally, we are honored to have Sherry Pugh, who is the chair of the Age-Friendly Minnesota Council. Sherry has an extensive background in community housing and business development in low-income communities. She has worked at the national, local, and regional levels. However, the last 25 years, she has dedicated her efforts around aging issues, joining the Board on Aging in 2010. She has served for 10 years as a member and currently, as I said, is the chair of Age Friendly Minnesota. Thank you to all three of you for being here today. And to begin our discussion, we'd like to give each panelist about 5 minutes to introduce themselves, share insights about their work, and reflect on the importance of bridging aging and disability. And we would love to hear any immediate thoughts or reactions that they might have to Dr. Putnam's presentation. So let's start with David, followed by Tori, and then Sherry.
Thank you, everyone. Pardon me. My name is David Dively, and my visual description is I'm a white, bald man with a gray, blackish shirt on and a purple shirt underneath it, and I wear glasses. So, as I mentioned, my name is David Dively, and I work at the Minnesota Council on Disability. One thing to note specifically is MCD is not like most government agencies. We are independent, which means we do our own separate political proposals and agendas than what you might think of from the governor or the legislature. So 50 years ago, they created the agency, and the primary role is three things: doing public policy training, public policy technical assistance, and research. We also do other things as well. So everything is kind of led by policy, and you can imagine during this time of year, there's a lot of policy going on, both at the national and state level. Our focus area is primarily state, but we look at all levels of these issues. One of the biggest areas where our work at Minnesota Council on Disability intersects directly with our aging communities is one, obviously in the Medicaid world, where a lot of the funding for services at some point is connected before it's kind of split off a little bit. And then also in emergency preparedness and disaster recovery with the access and functional needs committees, which are primarily the emergency management planning tools for older adults and people with disabilities. What's interesting is the areas of housing also have overlap, transportation as well. I will say that our council is made up of governor-appointed citizens of Minnesota, the majority of whom also have disabilities. And we have a staff of 11 people on staff, including 2 people that do assistance and technical support around people's obligations for disability access rights, things like that. And I look forward to sharing more with you all later.
Thank you, David. Tori.
Well, yeah, thank you for that introduction. My name is Tori Marhart, and I use the she, her pronouns. I am wearing glasses, and I have a red and navy blazer on, and I'm just happy to be here. So as introduced, I am currently the Associate Vice President of Older Adult Services at Lutheran Social Service of Minnesota. And Lutheran Social Service serves more than 91,000 individuals and families each year in all 87 counties. And actually, we have some services in North Dakota as well. Our services are wide-ranging and include healthy meals for older adults, adoption and foster care, senior companionship, services for youth experiencing housing instability and homelessness, services for veterans, senior companionship, and supports for people with disabilities that allow them to live the lives that they choose. The services we provide support foundational human needs and are rooted in the Lutheran tradition of serving all people, and provide programming and services that inspire hope, change lives, and build community. And so that aligns so much with my background, as I am a licensed social worker and I went to get my MBA with a focus in healthcare management. I know that I wanted to help support the programs. And, I wanted to work with kids after college, but when I returned to my rural Minnesota hometown, the opportunity that existed was at the local nursing home. So I started my career in nursing homes in the rural area in Minnesota, and then moved to the metro area. And later then transitioned to supporting our MSHO and MSC Plus programs, which is our care coordination programs. That's called Minnesota Senior Health Options, which is primarily dual eligibles of Medicare and Medicaid. And so then I shifted to working to keeping people out of the nursing homes by those assessments, education, and service referrals. Ultimately, that's what led me to LSS. And when I got to LSS, I was offered an opportunity to work with people with disabilities and expand my opportunities through self-directed services, host home services, which is also called life sharing, and learn about our Camp Knutson experiences. So really broadened my experiences. And currently, after the last 18 months, I'm back focusing on our older adult services across the state with our senior nutrition. We also do daycare meals. We served over 1 million meals last year. Caregiver supports, companion services, and also, working to prevent or avoid guardianship and supported decision making. And so I think my experience spans across aging and disability, and honored to be here and listening to the presentation. Even though I've had 25, 26 years of experience in these spaces, there still is that divide and opportunity to bridge these services, I think. And I think the innovation and leaning on each other will really be key to that success. So thank you.
Thank you, Tori. And Sherry, please.
Good afternoon. I'm Sherry Pugh, and I am a short African-American female with gray hair who's 74 years old, who's learning how to adapt as I move into disability, which has been a learning lesson for me. As chair of Age Friendly, over the last 4 years, though, we have been really mandated with trying to identify and support individuals, organizations, our government partners in making Minnesota a place where we are matching the aging access for our residents in the state. So while Minnesota has always pushed aging well at home, Age Friendly takes the greater look and says, how do we make our communities, our organizations and facilities welcoming to people aging and aging with disabilities?
Thank you, Sherry. What we have is a couple of prepared questions for our panelists, but please feel free, and we encourage you to put your questions in Q&A so we can direct them to the panelists. So my first question is as follows. How do we define aging and disability, and where do they overlap? How can we better connect academic research with real-world experiences in service delivery in Minnesota? Maybe we can start with you, Sherry, and other panelists if they want to weigh in.
Well, it's interesting. As I sort of feel like I'm the experiential person, learning this as I move through the different stages. Aging was always kind of a numerical thing, but with it, you felt that there would be physical changes. Those physical changes that happen as you're aging, some of which become or are considered disabilities. And sometimes we don't really know that. I was diagnosed with Parkinson's in 2010. The doctor said I had Parkinson-like, and I decided to take the lesser diagnosis and decide that I had essential tremors. And in that process, I also encountered some vision issues. So now I have low vision. And it was difficult for me to understand that these conditions, which had names, also represented my abilities and accessibilities to different things as I was aging. And so I think that, they come together, but they come at different stages for different people. And it's this process in which it may take you time to catch up. Your disability may be moving faster than you're acknowledging that it's occurring. And so I think that those are part of the defining and helping people to understand and reflect, and also to accept your disability. Not to accept it in a defeating way, but to accept it in a way that you are able to control and direct your life chances and opportunities and activities.
Thank you, Sherry. Does anyone else want to weigh in on that question? David?
Yeah, this is David. I'll briefly speak to that. It's really interesting, I think, in both the community of disabled folks in Minnesota as well as in our aging communities. I think there's I think of how people receive rights and do their work and live as like a triangle, right? So we have on one side, you have the rights and obligations and civil rights kinds of parts. You have the capacity to deliver services, funding, all that stuff. But the third part is really, really hard, which is like the social attitudes and biases part. It's really hard to change, and sometimes that's the biggest barrier that's we're trying to make policies to kind of work around. And in both of these communities, like economic contribution to society is sometimes seen as the measuring stick for how much you have as a value as a person. And that can be really profoundly negative, because we were just talking about, Sherry talking about pride or being accepting of your identities. Part of that really has to feel like you are allowing yourself to say, yeah, being disabled makes I'm still fully human, and that could be applicable to for the aging community, but I can't speak for that. And if that is true, that we really think that we're all literally equal and fully human, deserving equally, how would that change things? And we can share more about that, but I think that's an interesting question. I did see some interesting comments about discrimination and attitudes about that, and I think that could be a good space to get into also.
Yes. Actually, I'll ask one of the questions from chat a little bit further down because I think it ties in your comments. And that's a question from Peter Spewitt. And it says, would it help us as a society if more of us identified as a person with a disability? I believe that more people have disabilities than we publicly acknowledge, especially as we embrace conditions that are on a spectrum, like autism, neurodiversity, and the prevalence of mental health conditions and chronic health conditions that come with disabilities. I don't know if you want to take it, David, and anybody else.
I'll just briefly, and then I'd love to turn it over to my panelists. I think so, yes. Although I should say, I should take it back up. A lot of folks within the mental health, mental illness side of the disability or health and human services world do not identify as a disabled person. But so I just want to name that sort of. But I think the more we can normalize things, I think it can only benefit people, because right now it's very much so like othering, like they're different because of that reason, they're different for that reason. So.
Thank you. Anybody else? All right. Well, then I'll go to my next question for you, and then we'll keep taking questions from Q&A. Thank you for putting those in. This question will be to you, Tori and David, but also others, of course, answer as you are able. And it goes as follows. Older adults with disabilities in rural areas often face significant barriers related to transit and housing, limiting their access to essential services and opportunities. How can policies and programs be designed to better support aging and disability needs in rural communities, ensuring equitable access to essential resources?
I'll jump in there. I think understanding the population and the geography of rural Minnesota is really important. So, for example, when we provide services, it will say that transportation is available, and it's available to all, but it's possibly not available if your medical needs are too high, or if your behavior, if you have a severe mental health and you are no longer able to access the transportation. And so then the services are no longer available, which even makes it a little bit more challenging in rural Minnesota when there isn't possibly an alternative, unless there is a family member or a volunteer to provide those services. So I think it's understanding that the access is limited by some of the conditions that we're trying to support the most.
Thank you. David, any comments from you?
Yeah, I would agree with a lot of that. I think right now, unfortunately, I think the availability of transportation and housing is really dictating where people live and which communities they participate in, and not where people want to be or maybe where they think is best for them. And we, in the greater Minnesota part, certainly not every city, not every county, are heavily utilizing Medicaid services, which is also has some challenges right now around the viability and long-term funding for that. And so we also want to look at what we can do at a state level. This really brings up the other challenge, which is that most of the services that are provided for disabled folks, and I think for the aging community as well, is very detached from the actual delivery of them, right? From like the lawmakers on the federal side, even at the state side, like the oversight and regulations are very detached from the frontline social workers working with people. And I think that makes it very difficult to make system changes that are meaningful. And so I'll say more housing and more transportation.
Thank you.
In age friendly, we've found both Metro and Greater Minnesota that the two biggest issues are housing and transportation. And I live on sort of the fringe. I'm on the edge of where the urban suburban ends and the farm country begins. And I know just from my own personal use, the challenges of managing metro mobility as a transportation system, or coordinating rides with family members, or utilizing a volunteer service that's in our community. It becomes, it takes a lot of time. And I think that that's the other challenge. As one of my disabilities of Parkinson's, my doctor said, I needed to quit trying to double task, that was probably one of the things that gave me anxiety. But when you're trying to manage your transportation, scheduling how much time it takes you to travel, plus figuring out how to book that travel, and then utilizing those services takes up a lot of energy from people. Your home. I live in a community where most of the homes were built between 1970 and 1990, which meant many of them are split level homes or multi-level homes. So for an aging household, I'm in a household that was common in my community, but not a household that was designed for me to really age there over time. And so I think that those things are housing cost, housing styles, what it takes to make them accessible, and how you hook up with organizations that can help you do that are also important in the process.
Thank you, Sherry. I'll take a question from Christine Mueller, which is a kind of a comment, but maybe also a question we can discuss. And it goes that in a spirit of reframing aging, I think we need to be careful that aging and disability are not viewed the same, or that when one is aging, one is also disabled. Michelle, I don't know if you want to take that, and maybe other panelists as well.
Yeah, that's something I've heard a lot, and I've heard for years, and I think that is that's a real valid concern and thought that a lot of people have. And I think sometimes there can be a lot to thoughts and feelings around those things, I guess I should say. But so what I like to do is I like to say, for me, I like to think about aging as a process. We're growing older. It's like, if we're lucky, we're gonna grow older, and that's a process of us moving through the life course. Disability, from the work that I've done, is really an experience. It's a situation. It's the person in an environment, and if the environment isn't supportive of them, however they come to that as a human being, then there's a disabling situation. So older people are more likely, as they grow older, to experience disabling situations because the nature of their beings change, whether it's cognitive or physical, or we all have that happen. So as we grow older, we change, and the environments we're in can become more difficult or less, difficult for us. And I think one of the bridging pieces is, so we don't want to say that aging is the same as like entering into a situation where you would experience disability. But at the same time, we don't want to say that having disability at any age is fixed, right? Disability is very contextual. We can eliminate disability. We can make it so much easier for people with differing abilities and natures and they're just different to live well. And we don't always do that. So I think sometimes there's room for a much bigger conversation about what's aging and what's disability, and room for us to learn a lot from each other about the different models we have of that. I think in the disability community and in disability scholarship advocacy has done an exceptionally good job of disentangling humanity from the situation. And I don't know that in the aging side of the house we've done as well as disentangling the older person from the situation. And the difficulty is sometimes older adults accept that there are things that are difficult for them to do or hard for them to do, and that can lead to negative outcomes for them. And they accept it in a way that maybe somebody younger with a disability wouldn't, because they would think it's their right to participate and engage. So there's a lot to discuss there. But again, just I sort of use aging as a process and disabilities and experience, and they intersect in different ways at different times.
And Chris posted, since she has the question, that I really like how you framed it. Experiencing a disability is a situation. Do any of the panelists want to comment on the definitions, I guess, aging and disability and the framing that Michelle provided? Sounds like
Well, I
go
would
ahead,
add,
Sharon.
I think, in experiencing the disability and talking about the change, I always found that technology has been part of my need to make change. So in 2010, I went back to graduate school, and I was experiencing vision challenges at that time. And I was also experiencing Parkinson's, but didn't realize it. And it was a student who told me, as I was sharing with her some of my challenges on reading all the readings we had to do, she said, you should go to the disability student office and they can help you. And she was a disabled student. And so I thought, well, sure, why not? I go to the office and they said, well, you're not really disabled, but they did help me because they said, well, if you use an iPad for reading, you can get text read to you. You can adjust the screen lighting so that your low vision has adjustments. So, part of that transition for me was now I had a new technology I had to learn, which would help me in that process. And even in my Parkinson's, I have what's called a now deep brain stimulator, which is a battery to help stop my tremors. And so again, I'm now looking at technology that I have to learn to utilize and help with the change that my disability is bringing to my new lifestyle. So I think that's an interesting piece, especially for those of us who are aging, because I always tell people when I was in college the first time in the 60s, the computer was a building behind the engineering building. It was a building, not something you carried around on your shoulder. So
I love that, Sherry. Thank you for sharing. I've noticed a couple of questions, and David, you alluded to this, that get at discrimination in healthcare spaces. And so here's a comment from Anna, which says, I would say one major challenge in both disability and aging spaces is discrimination in healthcare spaces, thinking Section 504's updated regulations that were released last spring. And there's also a comment from Judith, who talks about her brother with Down syndrome who lived in a community to almost 70, but as dementia and physical limitations came to him, he went to a long-term care facility where he faced discrimination, with some folks saying that persons like him should be served elsewhere, not being included in facility activities, and caring providers who didn't know how to serve him as a person with impaired condition and degenerating neurological conditions. Could you talk a bit about the presence of discrimination for people who are aging with disabilities and some strategies to address it?
Sure. This is David speaking. Yeah, I think, well, I'll back up. This is one of the difficult spots we're in right now because as one of the messages correctly said, last year, 504, which is the oldest first disability rights bill, the law, passed, had the first time in 50 years had updated rulemaking processes, right? And so you can think of everything from what makes accessible imaging equipment in a clinic room to the inability to treat people and provide scarce resources based on a disability or lack thereof. Like, it's a very broad reaching 504 thing. The primary issue that I have with disability rights, and this would also be true, I believe, for aging rights as well, would be that it is entirely reactive, right? We set a law that sets expectations, like you cannot be prevented from doing this and you must be allowed to do this. But nothing actually forces people to do it, right? It's all like, hey, if we set this expectation and add a penalty for doing it wrong, people will eventually do the right thing. And that might be true, but it's been a long time and we're not there still. And what people are starting to look to now is if there are increasingly different ways of making proactivity or like assertiveness part of our system. So right now, for example, if you have a discrimination claim, you need to be discriminated at work, and then you need to file, and then hopefully get your job back or whatever, and so on and so forth for the different spaces. Plus, very, very few cases are actually investigated and or reach to a conclusion. And so while Minnesota has one of the strongest human rights protections in the country, far greater than the Americans with Disabilities Act and other civil rights laws, we still take a year and a half plus to take a process of a complaint, and many of them are not resolved that way. So it is a real issue. And it also kind of gets to some of the issues we have, which are much more cultural and social. Certainly disability and aging, of course, as well, have a medical element to it. But as Michelle has been saying a few times here, there is a huge part that's up to the culture and social area in which you live that can really define how much those disabilities affect your daily living. In this case, maybe also aging. And unfortunately, the idea that we should have disabled folks be somewhere else is not new, right? That's long time coming. And I will say on that note that the Olmstead decision, which was used earlier in this, is also just a Supreme Court decision that was 5-4, and most of those 5 are not on the court anymore. And so there is nothing that could stop that from going away tomorrow like that. And that's just the reality of it, which can also be pretty scary. And so I think that's where a lot of people are right now, as far as their rights being protected.
Thank you, David. Anybody else? Michelle, I don't know if you have any. Oh, Tori, you're unmuted.
Yeah, I can just add, some examples of things that are kind of happening is, I mean, it still happens when a person with a disability goes in, maybe with one of our teammates, and they're not asked if they're sexually active, right? Because they have a disability. And so that totally changes the trajectory of their treatment plan and their planning for their future in healthcare. Also, what I'm hearing from our team is that our folks prefer to be in clinics. So the virtual appointments, even though they're handy and they're great, that flexibility, but there's these preferences of having, getting a little bit more comfortable having people come into their homes and do some of that blood draws, but they're used to the traditional medical appointments. And also just the dependence on us as providers to help help people understand their choices and the importance of their health care. I think that's where we as providers supplement things that are happening in the healthcare realm to help people either go back to their practitioners to say that's not what I want, or I didn't understand, or I need further instruction. So I just wanted to add that.
Thank you, Tori. We received a question that I think could be a kind of a good transition as we start thinking about solutions. And the question states, the problem for researchers is that we have ideas for bridging, but funding is not available. And sometimes organizations don't want to collaborate. How do we get organizations to partner in this space?
I'll take a crack at that. So having had a career that is trying to get different entities to focus on something that's bridging, I think there's a couple of ways to think about that. One is that there are challenges in doing research related to thinking about people growing older with disabilities, and those are challenges that researchers can solve in a way. There are things related to technical things about measurement or survey items, and there's information we don't have available because we don't collect it, those sorts of things. So that's on the researchers to do a better job of thinking about what do we need to know and how do we need to know it. And for me, that is part of community collaboration and engaging with stakeholders. What's important to know, what's important to you. I can tell you fundamentally one of the challenges is in a lot of our large data sets, even data sets that focus on later life, we ask people if they currently experience disability or they have a disability, but we never ask how long. So we can't tell if you're a person who's had a disability for 40 or 50 years because we never asked. So that's on us to do a better job. And I think it motivates me in the way to think about how do we think about disability, like, and how do we think about it over the life course? Knowing that it's influential over the life course, we should think about it differently in our data, and we don't always. I think in terms of partnerships and collaborations, that too for me is having a better ear on the ground and thinking about how do you engage with organizations? How do you think about those partnerships? How do you think about studying things that are meaningful to people who are doing the day-to-day, like the members of this panel, in addition to the things we might think are interesting? But how are you actually building those partnerships and collaborations, and working to make sure that you're producing information that's useful and actionable. And I think a lot of us try to do that, and that often boils down to incentives and rewards and financing and money as well too. So I would say that there's bridging that needs to happen at the institutional research side in terms of understanding the importance of funding this work, understanding the importance of funding research on aging with disability. But also I think this entire area, whether it's research or services and supports or just things in general, are significantly underinvested in. A lot of the initiatives we have had related to bridging are shoestring funded in the first place. And so for me, the progress we've made is pretty substantial on the tiny fraction of money that's been available out there. But if you really wanted to work on this, you would really put some money into it. And it's not something, for me at least, it's not something that private organizations can do as readily as you can at a bigger level.
Thank you, Michelle. And there's a really helpful question that connects us to local context. So maybe panelists could take this. And the question is from Adam Sumala, which says, Minnesota has seen a chronic lack of prioritization on aging and disability policy and investments from both state and federal lawmakers. What tangible actions specific to aging, disability, or across both do speakers suggest each participant listening today could get engaged in right now to mobilize our collective strength?
I can speak to that, or I can start. Great question, Adam. Working in the different sectors that I have worked, I have definitely, there's a lot of priority on waivers and Medicaid and but not specifically older adults. And I do think that we need to tell the story, continue to be advocates, speak up. My first impression of when I went from nursing homes to working with self-directed services, I said, those moms of kids with autism, they are going to change the world. They are, and it feels like we need that type of force in our stories for older adults. And it's going to take all of us.
I love that. Sherry, any insights from you?
Wow. Well, I guess one of the things that we talked about was housing. And I think that we have a strong housing finance agency in this state, and we have nonprofits that are engaged in housing. And so an effort to provide the financing for development of new housing, but maybe also a large scale effort to help in making the adjustments to our existing homes so that they're livable, and maybe also changing the market perception of what housing should be, so that we're building new housing that that will long-term be accessible. And right now we're into great rooms and 3,000 square feet and 3-car garages. Is that really the livable home that we need? So maybe creating that model for a livable home and using the strong resources we have to build that housing stock for the future.
Thank you, Sherry. David?
Yeah, this is a good question. Well, first I'll say kind of the first thing that comes to my mind, because I work in public policy, is voting, right? So the disability community, although I say community, it's not really, obviously it's like 5, 6, 7, 8 smaller groups, right, that we kind of lump together as the disability community, but is in Minnesota anyway, is the largest voting bloc of any people group in Minnesota. But you would not think that based on like the power wielded by their electoral influence, right? However, the aging community is also one of the biggest voting blocs in populations in Minnesota. And through that, because of there's kind of like that famous trope of like the faithful voter, right? And so I would say, first of all, voting, like that's the biggest thing. And in Minnesota, if you go to the legislature, the Human Services Committee is the one that does a lot of the Medicaid stuff and services that we're talking about today. Might be the most bipartisan or nonpartisan of the committees in the legislature. Not to say it's not partisan at all, but Minnesota, I think, despite having some issues for sure, has a strong history in that way that is really unique, and other states can be quite envious sometimes of that here. But I will say that we need more. We have like, let's say we have like 6 to 10 legislators who are going to support these issues like wholeheartedly, and they're fantastic. But we have 200 legislators approximately in our legislature, and a lot of them are in greater Minnesota and other parts that are not Twin Cities based, right? And so we need those people to also hear from their members that we have, maybe it's aging or it's disabled or both, people in our districts that we need to care about. It's not somewhere else, it's not an other thing, it's here too. And also the importance of how these larger economic systems are affecting us. So when you think of what kind of issues do you support, things like that, we want to make sure we're prioritizing ways of the care workers force. We want to make sure we're talking about how funding is delivered and if it's a block grant or not. So all these things are very weedsy and kind of difficult times to get our mind around, but they're all very important for how we actually do the work. So I would say people need to hear from you, your stories, as Tori was kind of mentioning about the moms of autistic kiddos. They're way more important than like paid lobbyist people like me. So
I love these action-oriented answers because there is something each of us can do, right? Including all of our participants here. Sherry, there's a question that came in for you that I haven't had a chance to ask yet. And the question is as follows. Sherry, what are the pressing needs for age-friendly Minnesota?
The, repeat, what, the practicing?
What are the pressing needs for age-friendly
press.
Minnesota? It's from Rosina.
Okay, well, right now, the pressing need is that we have legislation introduced at the House and the Senate to continue age-friendly and potentially to fund our grant program, which we've had two cycles thus far and funded close to probably 200 individuals, organizations, and communities to do age-friendly work. So that's our most pressing thing that we have right now. Thank you.
Thank you, Sherry. There's a question from Adria Navarro. I hope I pronounced the name correctly. And I think it builds on some of your previous responses about what it is we can do. The comment really goes, I get concerned about building the workforce to serve persons of varied abilities. Could the panelists and Michelle talk a bit about how are we building the workforce to support the needs of people with varied abilities?
I'll go first, but mine will be a very academic response. So I recently was in a school of social work. Neither aging or disability or something that's focused on and really taught very much in the curriculum. I think that's true in social work. It's true in nursing. It's true in medicine. It's true. Pick a field. It's true in English. It doesn't matter. Like they're just not. Unless you choose to specialize in a population or an issue, you may not have any content on that in your training. So it's a lot of what people get in the field. And I think that's fine and it's good. And you can get a lot of good mentoring. But if your mentor doesn't have much training either, then we have a bit of a capacity issue in terms of knowledge and skills. And it's not to say that people aren't doing good jobs and good work, that already they are. But in terms of our ability to focus on, moving new knowledge or research information out, like what do we know about the experience of aging with disability? What do we know about building environments that are accessible? What do we know about including people in the work that we do? Like that doesn't often funnel out very well. So I think there are real workforce issues about how many people we have to do the work that we need to have done. But there are also real issues about how are we preparing people to do that work so that they're doing well, and the people that they're supporting and helping are doing well too.
Thank you, Michelle. Tori, David, Sherry, anything else to add on the workforce comment?
I'll add a little bit. This is something I'm very worried about as well. I definitely, the funding allows for reimbursement of our direct support professionals at such a low rate that many of the people that are doing this work are dependent on benefits themselves across the state of Minnesota. Also, some of this can be done with volunteers and trained volunteer programs, formal volunteer programs, but also the volunteer demographics are changing from long-term volunteers to short one-time volunteer opportunities. With self-directed services and consumer-directed supports, that is a really great option that the Disability Network uses. It's less used with older adults, but it's only a great option if you have those built-in supports that are able to be your caregivers and you can recruit and kind of manage those services. So I'm very concerned and worried about this, the ability to support our workforce in this area.
David,
I'll just briefly say that in 2020, when we did our last carving up of the state into districts from the census results, and every 10 years, they see all the states that have grown and shrunk and all that stuff. Essentially 100% of the population growth in Minnesota was due to immigration. And when we last got our numbers right in 2020. And you see that in our care workforce, right? It's predominantly people from communities of color. Sometimes it's lower economic, and some of the federal decisions that are being made are going to really affect the availability period of people to do some of this work. And that makes me very nervous because at the state level, there's not a whole lot that we can do on that particular issue, but it will be very critical for us as we move forward.
Couldn't agree more, because workforce is such a huge issue impacting both, as we said, people with disabilities and older adults. There's a really insightful comment from Judith Miller in chat, who talks about her experience living with an invisible disability of Crohn's disease, and her brother was Down's, lived to 70. But she really talks about the need to do all we can do to help each other live and die with dignity. She said there is a need to set the vision. Yes, funds are needed, but the commitment to the vision comes first. And then she talks about the work of Judy Heumann at the University of Minnesota speech, who said that people who are aging and people with disabilities have common policy and political interests. And hence we need to build a coalition, which I'm hoping some of these webinars and ways for us to connect with each other could support. And for all of you here who joined this webinar, I have one more question to the panelists, and maybe we could start with you, David, but really anybody else who wants to answer. And that is, if we could create a future where all barriers to accessibility and inclusion were gone, what would that look like? What changes need to happen in policy, funding, or community systems to make this possible?
Yeah, this one's a big one, right? I'll give it my shot, but there's going to be a lot for other folks here to speak to as well. Particularly like on the what would need to change part. Guardianship reform is a major part right now where the aging and disability communities in Minnesota have kind of come together and where we have the guardianship task force to focus on both of those issues at the same time. We would need guardianship changes that maximize civil rights and independence as opposed to how easy it makes your financial trust situation. Like we're really prioritizing things kind of backwards sometimes. We would have to have things like accessible transportation, including things like Uber and Lyft throughout the state anywhere. We don't have that anywhere in Minnesota. So that would be significant. And we would need to change some of our zoning that people use, sometimes local zoning issues, to prevent communities of aging or disabled folks from living in those communities. So there's kind of from the top all the way down. But I'll say, unfortunately, one of the biggest things we really need is people's attitudes and understanding and interest and curiosity in learning about people who are different than us.
Love that. Anybody else?
I would just
Michelle?
echo that. Oh, and thanks, David, for saying that. I feel like some of this bridging work's been going on a long time. There's only so much you can do with structures and systems. For me, I think there is a lot of space for people becoming more comfortable with people who are different than them. Speak differently, hear differently, use their bodies differently, think differently, all of that. And that's a societal thing. If you really want to include everybody, you have to do the work to include everybody, and that includes working within your own views and thoughts and ideas about what you're comfortable with and becoming more comfortable with a wider range of the heterogeneity of the population. And I think if we can do that, we've got a better shot at creating more inclusive spaces overall.
Thank you, Michelle. Sherry or Tori, any last minute comments?
Well, my last minute comment is a request, and that is on Wednesday morning, Age Friendly has a hearing before the House Committee for Human Services. And we need people to write their legislators and just simply say, support Age Friendly. I think at this stage, a simple message would be of great help for us as we move that bill. And if any of you are coming for the rally that morning, you're welcome to come to the hearing. The hearing starts at 8, and I think there's a rally at 9:30. So there's time to do both.
I love that we are concluding on an action item. And with that, I want to thank all of you. Thank you to Michelle and our outstanding panelists for your presentations. And thank you to all of you who joined us today. We truly do appreciate your time and participation. We also want to thank the Institute on Community Integration for co-sponsoring today's event. Now, in the coming days, you will receive a follow-up email from us with a list of resources we have mentioned, a link to the recording, which will include the slides and contact information for all of our speakers. Additionally, you will receive a satisfaction survey from us. We really do welcome your feedback as it can help us to improve our webinars and better serve you as our community. So thank you all again, and we hope you have a wonderful day. Take care.